Hello, everyone. Thank you for taking the time this afternoon to join us for our NCCRT Policy Action Task Group call. We welcome you all to our second year providing these pre-annual meeting task group briefing updates for members, and we are extremely excited to share the progress we've made on our 2017-2018 task group action plans. For those new to the NCCRT, much of the work of the Roundtable is developed and completed through the commitment and voluntary actions of our members within our task group infrastructure. We currently have 6 active task groups with focus areas in community health centers, evaluation and measurement, family history and early age onset colorectal cancer, policy action, professional education and practice implementation, and public awareness and social media. Each year, our task groups hold working sessions during the annual meeting to discuss emerging trends and topics, identify knowledge gaps and barriers in colorectal cancer screening, and consider strategic actions the NCCRT can take in addressing these issues to better assist and serve our partners committed to increasing colorectal cancer screening. So our first step in inviting this active participation and engagement from members is for all attendees of the annual meeting to take part in or watch a replay of these short task group webinar briefings. During today's webinar, task group chairs will recap the work of the task group to ensure that we don't spend valuable face-to-face time getting the group up to speed. Rather, the intention is that these in-person times can be used to advance key issues and projects. While there will be time at the end of this call for task group questions, we hope that we have kept these calls short and informative and to the point for your convenience. Before we get started, I'd like to share a couple of other reminders and comments. First, task group meetings for the NCCRT annual meeting take place on November 14th from 5 to 6:30 p.m., with the formal sessions of the annual meeting occurring on November 15th and 16th. Please do make special note of the task group date and time, as it occurs the evening before the opening session of the 2018 annual meeting. Second, should you have any ideas between now and the annual meeting on how we can better engage task group members, please share those with me, Caleb LaBelle, the program manager, or our task group chairs. As the NCCRT continues to grow and we continue to transition to the 80% initiative in 2019 and beyond, we want to make sure that we are giving ample opportunities for our faithful NCCRT members to participate and share their ideas and talents. Finally, please do make sure to check out the NCCRT website frequently, as it will include updated information on the annual meeting agenda, the speakers, task group activities, and constant stream of new resources intended to help you in your everyday work. So with that, I will now take the time to hand the mic over to Bob Smith, who will be going through our Policy Action Task Group action plan.
Thank you, Caleb. All right, you're looking at this first slide now that describes that this is a pre-annual meeting task group information webinar. Let's look at the agenda really quick. It begins with welcome and introductions, the task group charge, accomplishments, current projects, and possible topics for annual meeting task group sessions, followed by Q&A. And you'll see that those are fleshed out in greater detail as we go forward through this. Let's look at the leadership. We are having a change in leadership this year. Cisco Staples, who has served us faithfully and brought an enormous amount of background and expertise in the policy space, is leaving us for other obligations. And Linda Flowers also will be leaving us as a chair, but will stay on as a past chair and provide guidance and direction for the 2 new chairs. The 2 new chairs are Heather Dacus, who is Director of the Bureau of Cancer Prevention and Control at the New York State Department of Health, longtime Roundtable member, and David Woodmansey, who is Director of State and Local Campaigns at ACS CAN in Washington, who also brings an enormous amount of background in the policy space. The charge of the Policy Action Task Group is to answer the day's pressing policy questions around colorectal cancer. And there are many. Of course, what a task group really is set up to do is to identify those issues that are immediate and that are particularly suited for collective engagement of roundtable members to address, and to ideally address collectively. And that sometimes it involves collecting data that would be essential to actually know what next steps would be. The task group themes are thus far have been to address the copay issue, which has been particularly vexing when people go in for screening and find that they're getting charged because a procedure took place, or they undergo a simple stool test for colorectal cancer screening, and if it's positive, they suddenly face a copay for the colonoscopy. And in fact, the copay issue varies across the type of insurance that you have and the type of test that you get. And we're also seeing that there are a number of instances where the patient get charged inappropriately, and no one's really policing whether that charge was inappropriate, just simply because the provider used the wrong codes. We also are working to determine how to increase colorectal cancer screening for Medicaid patients and other newly insured, and perhaps the recent election will provide new hope in that area. The task group is focused on promoting solutions for paying for screening navigation, which we have seen is particularly productive in certain settings and for certain patients. We are trying to activate local governments around the 80% campaign, also important as we go forward and continue to try to use this campaign to elevate screening rates. And finally, to assist with the case for making the financial benefit for screening. As I hope you all know, colorectal cancer screening is probably the most cost-effective and demonstrated several times cost-beneficial screening test among all the cancer screening tests we do. Now let's look at the FY18 project plan that takes us through entirely through December 2017. We sought to create new resources to facilitate actions that states can take to facilitate screening among Medicaid beneficiaries. Again, this is a challenge in which across all the states there are likely many common denominators. We wanted to update and promote the Sustaining Patient Navigation Toolkit. We wanted to develop a curriculum on sustaining patient navigation, and based on the toolkit, we wanted to finish guidance to providers and patients on cost, the law, and coding, and to continue to explore the potential of developing a local jurisdiction cost modeling tool. Now, that's a mouthful, and for many of you who do not actually recall what that was, or this is the first time you've heard it, the goal here was to use simulation modeling to be able to convey to policymakers, for example, or even program planners, that if certain challenges were addressed in colorectal cancer screening, what would the outcome be? Or conversely, if you faced a particular challenge, you could essentially run a number of scenarios through the model to determine the most practical and most cost-effective strategy to propose. The idea is this would be a tool that local and regional populations could use to plan their colorectal cancer screening plans. We would envision that this would be ideally a widely used model, and in fact one in which different groups could compare results and actually even compare strategies. So let's look at our accomplishments for this fiscal year. We produced a report. The report follows up on the 2015 report, Colorectal Cancer Initiatives and Medicaid Agencies. These were the promising practices for state Medicaid agencies. Its purpose was to develop a deeper understanding of how higher performing states approach the challenges of colorectal cancer screening. These included Arizona, Maryland, Minnesota, Montana, New York, and Oregon. The data were gathered through telephone interviews with staff members from Medicaid agencies and state health departments, and these states also provided data and reports and samples of materials that they had used to support their screening programs. Our accomplishments also included the identification of 9 promising practices, defining a colorectal cancer screening metric for state Medicaid plans, support or mandate public reporting of colorectal cancer screening rates, developing an incentive program, value-based purchasing measure for colorectal cancer screening, providing education and technical support for managed care organizations and providers, how to collaborate with state public health staff, and how to work closely with federally qualified health plans that serve these clinics that serve large Medicaid populations. We also stress the importance of promoting evidence-based strategies and interventions, facilitating access by covering multiple tests without cost sharing, and in particular offering the option for either a stool-based test or a structurally based examination, which of course would typically only be colonoscopy, but in some instances could be CTC, has been shown to increase screening rates. It's really quite clear when you offer people only a colonoscopy, many people are not going to get it. And at the same time, we also want to make sure that people understand that stool testing is not a second-class citizen. We also identify that promoting test options, as we just mentioned, will improve compliance, reduce barriers, and address provider shortages, address geographic issues, and logistical constraints. We also produced updates on how to sustain patient navigation, how to sustain patient navigation toolkit. It's been a particularly popular toolkit. It's been downloaded quite a lot. One of the first roundtable to undergo a modernization makeover. It's one of our first toolkits to undergo this modernization makeover and make it more accessible and user-friendly. In general, our toolkits tend to be more lengthy than they probably need to be, and anytime we've had an opportunity to streamline them, we've seen that they become more popular. We have new online curriculum in develop. We do train the trainer model being piloted. These are small in-person pilot training sessions held in Colorado in 2018, and we've completed the update to the PDF of the toolkit undergoing final revisions. Continuing accomplishments, we provided guidance to providers and patients on cost, law, and coding. We worked through this project through the year, but it's proved to be quite complicated. What this is when patients undergo colonoscopy, there is a long list of charges that may or may not fall clearly under the ACA and may not fall clearly under the patient's awareness as to whether or not the services may be in or out of network for their particular plan. And so we had what literally amounted to more than a dozen different scenarios of the stepwise process that patients would go through for screening and potentially, what we would refer to as the screening continuum, to avoid making a distinction between screening and diagnosis. And the idea is to determine how these things are coded and the degree to which patients can avoid surprises by even in conditions where they would be making an effort to ensure that they did not have any surprise charges, they could find that they would have some. We had a very weak response to the survey, mainly because it was enormously time-consuming and daunting, even after numerous edits of the survey to make it actually as user-friendly as possible. Ultimately, we determined that the only way we were going to get the survey completed was to actually do it as a telephone survey where we would be able to walk the respondent through it. We ultimately are looking at these data and trying to figure out the best way we can provide guidance. This is something we'll discuss at the annual meeting, but the best way we can provide guidance is to help patients, and ideally with the help of their doctors, anticipate when they might be walking into a situation expecting that their insurance was going to cover the examination, only to learn that it would cover part of it and not all of it. So let's look at the FY19 project plan. We want to finalize and disseminate promising practices for state Medicare agencies' report. We want to finalize the patient navigation toolkit. There's many people waiting for that, and we want to finalize the curriculum and the trainer components of that. We also have and should be exploring the potential to define more clearly how state Medicaid programs can help pay for colorectal cancer screening navigation, which I think is going to be especially important for people who are having access to these kinds of tests for the very first time. We think we should do some brainstorming on how to regroup on the copay and cost maze. We might call it a conundrum or dilemma or any other terms that define it as particularly daunting and confusing. We need to think about what role the Policy Action Task Group should play. Perhaps we would want to have a united consensus statement on copays, deductible confusion. It might be particularly useful to more aggressively enlist member organization leaderships to collectively align around this challenge. And this might offer us a greater opportunity to elevate this to a policy priority in the coming years. And we might find, in fact, that with the House of Representatives now in Democratic hands, even though they certainly have many issues to cover, that we might find a more friendly orientation towards this. We want to pursue NCQA requirements to have all state Medicaid agencies track colorectal cancer screening. I think it's also a good idea for us to promote to the NCQA, which we've already initiated initial discussions about, to have new measures that identify performance and achieving screening rates early after screening is recommended. So instead of looking at rates from ages, say, 50 to 75, we want to see that, but we also want to see how well plans get their screening up between the ages of 50 and 52 or 50 and 54. At this point in time, screening in the 50 to 54 group lags the 55 plus group by about 50%. We also are looking at a white paper to help employees make the case for return on investment and value of colorectal cancer screening. And in FY20, we face new challenges also with respect to the change in guidelines. So, for example, for adults ages 45 to 49, that's about 12 million people. How are they going to be able to pay for colorectal cancer screening? We have seen that many health plans are already covering it, but almost certainly many health plans are not, and perhaps haven't even had a chance to confront the change. We want to demonstrate how the Affordable Care Act has had an impact on colorectal cancer screening, develop resources for policy and procedures on FIT, follow-up colonoscopy, in particular, where we can refer to this as the we want people to be able to choose the screening test that they most prefer, but not face any penalty for having done so. We want to look at the analysis of cost of screening versus treatment to employers, which we believe will be enormously motivating given the high cost of treating advanced colorectal cancer. We want to look at qualitative research demonstrating the need for Medicare to waive cost sharing for colonoscopy and continue to explore potential for developing a local jurisdiction cost modeling tool, which we described earlier. We have the modelers in place. They actually work very well together. We have not identified one, and perhaps we're even thinking about two or more, but we simply lack the funding to support their work, and that's something we'll continue to try to pursue. We, of course, want to hear what any ideas you have for objectives that are not on this list at this time, so please give that very careful thought before you come to the meeting. And we will continue this discussion on November 14th, that Wednesday afternoon, between 5 and 6:30. Please do not forget we're meeting in Baltimore this year and not Washington, and we look forward to seeing you there. Thank you.